with the processing of the insurance claim. Remember, we're gonna go through all these steps in order to um, to submit, to process these claims until we get paid and anything in between. So we were talking about how important it is to have a electronic billing or electronic medical records or the electronic um, way or method to submit and receive payments through the insurance company because it will be a faster way to do it. So that's basically what it is. So we've already discussed what is the submission. Remember, we're going to complete the form, has to be complete, has to be accurate. All the information needs to be withdrawn or collected from the encounter form. We learned that the encounter form is also known as the charge slip or the super bill. Very, very important terms that you need to remember, particularly for the test. So that's basically what it is. After these claims have been submitted, processed by the insurance company, they're going to be adjudicated. Remember, adjudication means each insurance claim is going to go to that particular insurance company that is the one who's going to pay for those services. They're going to review it one more time and they're going to see if meet the requirements for payment, if there are errors or omissions in the claim or something that they feel that it needs supporting documentation, they're going to return these claims to the billing department to be reviewed, to be corrected, and then resubmitted again. If a claim, which we're going to discuss later on, is denied, we can apply for an appeal. So that goes into legal issues. That's a little different. But to avoid all of that, we have to, once again, complete that claim as accurate as possible and attach documentation that supports diagnosis, that supports treatments and procedures. So we are not going to encounter any delays in the payment of these claims, because the most important thing is this accounts receivable. We need the money because we need, we already provide the services. We need to get paid. This is like you work for the week. Well, you already spend your time over there. You completed some task. Now you need to get paid. Can be waiting for someone to decide whether you're gonna get paid or not. During the process of completing the claim, if it is approved, the patient is gonna receive a statement. Remember, that statement that the patient receives is called EOB, which stands for explanation of benefits. We were talking about that yesterday. EOB, remember, this is very important for you because it's going to be in your exam. And once again, patients are going to come to the office claiming that, or complaining that they have received a bill and they're not going to pay it. But actually, this is not a bill, it's a statement, but they don't understand it, they don't read it. So you need to be familiar with these terms and with these notices. So when you see the letter, you know already it says right here, this is not a bill. No worries. The insurance has already paid for it. You don't have to worry about it. This is not a bill. Once again, we have to educate our patients, but sometimes they don't know. They haven't received this. This is the first time that they receive it. And when you receive something that you're not familiar with, the first thing that you do is you go to your doctor's office. And You're going to go there and argue. So that's basically what it is. We need to kind of, relax a little bit and understand the patient situation and trying to give them the best answer possible. If we are not familiar with this, we don't know what's going on, we direct these to the billing department. So that's basically what it is. Don't get involved if you have no idea what's going on. Remember, EOB stands for explanation of benefits. As the word implied, here is where you receive a statement, the patient receives a statement stating what services, when those services were provided, by who they were provided, and whether they were paid or not to the medical provider. So that's basically what it is, but it's not your responsibility. Just to let you know that these services have been paid, and they want to know if, they want you to review whether these services actually happens or occurred. So whether you receive those services or not, because we need to verify that, the medical doctors are billing for services that were actually provided, and the patient is the only one that can verify that, because if I didn't receive the service, I'm going to be contacting the insurance company and tell them, on that particular day, I went to the doctor, but I did not receive the services that are stated or written on that explanation of benefits letter. So that's the purpose. Remember, that's just to make sure, that medical providers are not committing fraud. And we got to be on top of that. So that's basically what it is. Now, that's the patient. The patient receives the EOB. The medical doctor receives an RA, which is a remittance advice. So this is the next one. Remember, RAO remittance advice is sent to the provider. Remember, the patient is going to receive, after we get paid for the services, the medical provider, the office, the hospital gets paid, then they send a letter, this statement, which is called EOB, explanation of benefits to the patient, but they also send to the medical doctor, because that is proof. Hey, I pay you for these services and this much. So that's basically what it is. It's another statement, but it is more detailed, because here it's telling what services exactly happens, how much time you spend with the patient, what was the cost of each of these procedures and evaluations, whatever the case may be, they give you details. Now you compare and say, oh yeah, they pay me what I was supposed to receive payments. They pay me for everything that I bill for, it was paid, or something is missing. So you can claim those. Hey, you pay me for this service. They said, but what about this other service? I sent it on the claim, but I didn't get paid for it. So now I need to submit, another paper requesting for these services that were not paid. And I didn't receive no explanation about the reason why these services were not paid. Or if they were not paid, they're going to explain you, I pay you for this, this. But this ones, I don't pay you because of this. Now, you have to clarify, you have to produce some, documentations to support that, or you might waive those charges because you might not get paid. So that's basically what it is. That information is for the doctors, not for the patients. So that is different. It's one telling everything, but because you're the doctor, you're the provider, I'm going to explain everything in details with all the charges that you submitted in your claim. So that's basically what it is. Remember, these RAO remittance advice is a statement of all the services that were rendered to the patient, but it is more detailed than explanation of benefits, because explanation of benefits is just for the patient. Hey, you received these services and you don't have to worry about has been paid to your doctor. Yes, verify that those services were actually rendered to you. On the other hand, the remittance advice is explaining the medical provider or the insurance company, but most likely is the medical provider, what services were paid and how much you got paid for each service, and if all the services that you submitted and procedures were paid or not. Once again, if they weren't paid, they're going to explain the reason. That's it. So now the doctor knows what to expect, what to do next. If everything was paid, no problem. We're just going to file this remittance advice in the financial documents. But if it's something pending that it was not paid, now we're going to use another form to claim for those services. So there are a lot of documents that we're going to receive, and we're going to send that this is like back and forth communication with the insurance, whether they pay or whether there is something pending to be paid. So that's basically what it is, or whatever requirements are needed to prove necessity of, of the procedure of treatment. So that's basically what is it entails to complete all these forms or these insurance claim forms to the insurance company. Maintaining claim files. So remember, this is another question for the exam. The CMS, what is the CMS again? The Centers for Medicare and Medicaid Services. Remember, this is the one that, supervises, let's put it that way, all these payments and services that, the medical doctor provides to the patients, and they are making sure that there are certain services needs to be paid or are covered. So that's basically how it works. So these claims, remember, after we have been paid, that that insurance claim needs to be kept at least for 6 years. So pay attention that this is not the medical record, because we are getting all this information about retention of documentation or statute of limitation. It is called statute of limitation as well. Everything that we have like an expiration date or a period of time in which we have to keep certain documentation, that is called statute of limitation. So get familiar with those terms. Every single time that you hear statute of limitation does not only imply for medical records, it's for anything, any documentation, whether about vaccines for the patients, whether it is this about, the medical records, or it is about all these claims, for how long we have to keep them before we can destroy or get rid of them. 6 years. So what exactly is this, financial documents that we need to keep? It says right there, it qualifies for the super bill. Remember the super bill encounter form, which is the same. All these summary of electronic claims. Whenever we receive, the remittance advice, not the EOB, because the EOB is not ours. That is for the patient. It's whatever we submitted. If we submit the claim, that has to be kept for 6 years. That's it. And where do we get the claim form? How do we complete it? Oh, we use the super bill or encounter form. It's the same. Or the charge slip. Any other information that goes along with, supporting the information, supporting these claims, if we get rejected or denied, we have to get those statements there too. And if we appeal for those claims that have been denied, then we have to have those documentations there until whether we get paid or actually we get denied for those, but we have to keep them for 6 years. Just in case something happens, then we have proofs. These are the receipts that we have. So we have to keep all this documentation. Whatever we use for the submission and the claims and all this back and forth communication between the insurance company and the billing department, all those documents needs to be kept at least for 6 years. So that's basically what it is. Once again, we're not talking about the medical records. This is the financial part. Remember, we're talking about insurance at this time. So one more thing. When you're taking a test, do not get everything into your head. Read the question once again. The question is going to tell you, oh, these are insurance. Oh, insurance papers. Wait a minute. That works different. This is medical records. Oh, that is different. That's how you're going to be understanding this. Do not mix everything, because that's what happened when we're taking a test. We mix every single chapter. No, every single chapter have different content. And this content is addressed differently when we take a test. If you take in, there are questions for anatomy and physiology, particularly the cardiovascular system, they're going to tell you, according to the cardiovascular system, oh, this is anatomy. Give you a medical term. Oh, it's a medical term. So don't mix that with any other things, because each chapter covers a determined subject and topic. And when you get the questions, they're going to give you the question based on, this is a phlebotomy question. You as a phlebotomist going to do this and that. Now go to phlebotomy only. Don't go beyond that. Oh, is that has to do with the medical records? Is that billing and coding? Is that medical terminology? Is that anatomy and physiology? No. So you have to focus on that particular question. Do not derail from these questions, because that's when you get the wrong answers. It's not a general thing. It's not, oh, I remember somebody said that. Yeah, but has nothing to do with whatever you're doing now. So what are you applying that? So that's how you take the test. If I'm talking about insurance, focus on insurance only. What qualifies? What is it that entails medical insurance? So you're going to be talking about codes, claims. Yes, we're going to talk about the patient's information, of course, because it's part of it. We're going to talk about privacy, confidentiality. But why? It's not medical records, but we're talking about the patient's protected information, or, protected health information. So don't try to think, if they're not asking you about medical records, they said claims for insurance. So now you know that these are being kept for 6 years. But if they said, okay, for how long we should keep, all the medical office should keep medical records. Now they're talking about medical records, 7 to 10 years. Now, if you do not have 7 to 10 years, because you're going to have it, but let's say they change a little bit. Well, depends on the regulations or the state regulation, based on each state, because each state has their own regulations. If you don't have that answer, because you have a bunch of answers, but none of them meets the requirements. 10 years, 15 years. No, there's no 10 years, there's no 15 years. And then it says, oh, regulated by state. Well, you go by the state regulations of the statute of limitation, because each state has their own regulations. So don't pick numbers just because the number that you're supposed to find is not there. If it's not there, it's for a reason. They're not giving you that because that's not the answer. So that's how you have to understand the questions. So these financial documents, particularly for the insurance claims and whatever other documentation you use to prove or to fight or to, collect that money from the insurance company, every documentation that was involved in that process, you need to keep it for 6 years. Okay. So open claims. What is an open claim? Well, an open claim makes sense. What is a closed claim? It is closed, it's been paid, it is being denied, nothing to do. What is an open claim? Well, an open claim is a claim that still is in the process. Still have not been paid. It's in the process. Maybe still in the process of evaluating, adjudicating. We have not get paid for it. So that's basically everything that it is in a process, whether it's being investigated, whether it's being processed, anything. We haven't been paid. It's open. You apply for something and you haven't received a definite answer. Well, it's still open. They have not closed your case, so it's still open. It's still in the process. So that's basically what it is. So let me give you some examples. It's here. Open claims includes claims submitted but not processed. It is open. It's somewhere in the cycle of the process. A claim that has been rejected. Remember, it has been rejected. It's still open. It's not closed yet because we can appeal this claim. Now, after the appeals, and they continue denying, says no, then the claim is not going to be open. The claim is going to be closed. So that's basically what it is. They assign these monthly. So every month we have to check because in a period of the month, we have to get paid or else something have happened to that claim. Remember now with electronic filing of these claims, of submission of these claims is a lot faster to get paid. So anytime that you have questions about electronic, this paperwork has to be done, or this particular process has to be done manually, electronic, and what is the advantage? Well, which one's better? Electronic. Always choose electronic because it's faster, it's less margin for error, and that's something that we are, that's something that we want, something that we're looking for. So that's basically what it is. So if this process, still ongoing, then we have an open claim. Remember, it's an open claim. So we have not gotten paid yet. So that's basically what it's called. Now, open claim is not the same as a clean claim. Remember, clean claim is a claim that has no errors, no omissions, it's complete. So it's ready for us to get paid. That's it. This is in process, open. Think about open cases, open, you apply for something, they still have not given you an answer, but still have not said no. So then still open, it's in process. Maintaining claims files. Now closed claims, see? This is the old one. This is the opposite to the open one. So what is a closed? What is a closed claim? An insurance company includes all claims that have been processed, completed, and appealed. See? All those claims. Now, this is done or filed per year, over year. So every month, remember that we send claims are for this particular month, so we put them together. These claims, because it takes long, it can take 6 months and probably a year for us to fight the claim, to appeal for a claim that has been denied. It can take a long time. So for that reason, we kind of use a time frame of 1 year to put all those claims that has been closed. So that's basically what it is. So it's very, very important to understand what is a clean claim, what is an open claim, what is a closed claim. So that's basically what it is. Remember, the patient can come with paper saying that, oh, I have this bill from this, and well, probably it's an old bill and probably it's already in collection. So send them to the billing department. Don't get caught up with this situation. So that will be close. Unassigned claims. Now, think about this. It's not being assigned already. So something is going on, right? So let's see what's going on here. So an assigned claim refers to a claim submitted by a healthcare provider who does not accept assignment of benefits. Oh, here again, we're going through this assignment of benefits, meaning that they will not accept the amount of money paid by the insurance company as a full payment. So remember, sometimes, you do not want this amount of money. You agree with getting paid this amount of money, but the insurance company is telling you otherwise. It's telling you, well, we are paying you this. Remember, they saying you, the provider, a remittance advice, and they explain you in that particular statement what is it that you're getting paid and how much you're getting paid for those services. So if the provider sees that, if this is the medical provider who's the owner of the office, or the billing department sees that, immediately they're going to reject this payment. So they're going to say, no, we're not agree with this. So this is not what we contracted. These are not the values and the prices that you will pay for these particular services. Let's put it that way. So then what's going to happen? Well, it's going to be an assigned claim because we are not taking the money yet, because that's not what we agree with. Think about this. You're selling someone something, bicycle, and you agree for selling the bicycle, let's say for $200. And the person comes and pick up the bicycle and says, hey, I'm going to pay you just $150. Says, no, that's not what I agree with, right? So then what's going to happen? Well, we're going to be undecided there. Might get to a consensus, right? Okay, I'm going to give you 180. I'm here. So, well, you will decide. But you're not going to give it that easily. So that basically, so the provider already, provide the services to the patient. Now we're going to get the money that the insurance was supposed to pay them. That's basically what it is. So that's how it works. And sometimes, they agree that, the balance should be sent to the patient. So think about it. Sometimes might be a problem because you know that the patient sometimes is reluctant to pay or not willing to pay. So we don't want to go through that because the agreement I have it with you, the insurance, not with the patient. So the patient is, responsible for the balance. But if it's something that the insurance has to pay, should not be a burden for the patient. So that's basically what it is. Now, another reason is because this not commonly happen, but it happens. And another reason is because the provider is a non-participating provider. Now, remember, we talk about this. A participating provider is a provider that signs up with this particular with this particular insurance, and they agree to get paid for the services. I have a contract with you. It's like I'm hiring you, you're my employee. So I explain you what your task is, what your schedule is, and how much money I'm going to pay you for the time that you're going to be working. And that can be weekly, it can be bi-weekly or monthly, whatever the case may be. Well, the same these insurance companies contracts with the medical provider or the hospital. Sometimes you have to receive, the services are not provided by the insurance. It's not covered, or you are not participant. You are not participant. The patient has the choice. Remember that this is not a patient who needs a pre-certification, pre-authorization. This is a patient who has a work-related, group-related insurance or private insurance, where you can select another doctor outside of the network. You don't have to be a participant. Now, the chances of receiving patients that from insurance that you're not participating is that you have to accept whatever money they offer you because you're not participant. So that's basically what it is. Let's say you do not work for me, but then sometimes, I need someone extra. You're not part of the payroll. We need someone to work for certain days, but that's it. You have to accept whatever we offer you if you need it. So this is what happened. If I'm going to take a patient and I'm going to do a procedure, but I do not participate with this insurance, but the insurance allows the patient to be out of the network so I can participate. If I'm not participating, then I have to accept whatever money the insurance pays me. I don't have contracts with them. But before you do that, you have to find out, hey, how much they're going to pay me for this? Is it worth it for me to do this procedure, or are they not going to pay me much? So you have to find out. But sometimes you just take the patient and you just bill for them and you have to accept whatever it is. But sometimes depends on the procedure, because some procedures are very complex. So then some medical providers probably want a little more money. That's what happens in insurance. So that's basically how it works. So if you are a non-participating provider, so in this case, sometimes that's what the problem with unassigned claims are brought to, to this situation. So that's basically what it is. So sometimes, we go back to like we were doing before. If you are a non-participating provider, now this is what's going to happen. The money is not going to be sent into the provider. The money is going to be sent to the patient. Now the patient, because the provider is going to bill the patient somehow, because I make you sign a paper. Listen, I do not take that insurance, but I'm going to tell you something. If the insurance doesn't pay me because I charge this much, if the insurance pay me this much, you have to come out with the balance. So the patient agrees, the patient signs the paper. Now the insurance company sends the money to the patient and the patient pays me. This is very seldom happening, but because most of the time the insurance, the provider receives money from the insurance, even though if you are not a participating provider from them. Because dealing with the patient is a hassle. It's a big pain. Can you imagine the patient receiving the money after they receive the treatment? They don't want to, reimburse the money or send the money to the medical doctor. So that was the reason that on the first place, that the patient no longer receives the money, because that was back in the days. But in these particular situations, it can happen. But most of the time, the medical doctors know that I should accept whatever the insurance pay me, because if I wait for the patient to pay me, maybe I'm not going to get paid at all. So it's better to receive something than nothing, right? So those are unassigned claims. It doesn't happen much, but it can once in a while happens, this unassigned, but mostly for these non-participating providers. Do not worry about unassigned claims. Think about closed claims, open claims, and clean claims. That's something that you should consider for your exam. Tracking claims submission. See, one of the beauties of electronic billing is that, you enter the system and you can see in the system exactly what's going on. Now, if you were dealing with a paper, now that is a different issue. Paper, you have to phone them. You have to call them by phone and find out, okay, what is the status of my bill? It's like when you call a company that you send something to be fixed and says, hey, what is the status of my car or my equipment or whatever you send? You're not gonna be able to go online and check it out yourself. Here with these electronic claims, now we can do so. So you can see every single step of the cycle of the claim on your own computer, from your own office. I'm talking about the billing department. So that's basically how it works. So then you're gonna see what is it, or whether something is pending, or whether something was not, well, it was required, like supporting documentation, which is the most common issues, or you make an error. Well, remember, they're gonna send it back to you. And you're gonna read there, claim is in process, claim is in step 1, step 2 processing, claim has been rejected, claim has been denied, claim has been adjudicated. You have to wait now for the insurance company to make the payment, and so on and so forth. So that's basically what it is. So it's just the way that we're going to kind of follow the claim to see where it starts. Non-covered services rejections. Now we're going to see if there were some problems with the claim. Now one of them is non-covered services rejections. If the services were not covered by the insurance, think about it. What are you going to do? Do not submit them. Bill the patient. Now, this is something that it has to be considered before you start the procedure. Why? Because if you forget or you kind of omitted the process of, getting the pre-authorization, and the medical provider, that was supposed to do the procedure, go ahead and do the procedure, and it was not covered, you can assume that every single procedure is covered by this particular insurance. It doesn't matter if it is private or governmental. Sorry. So that's basically what it is. If it's not covered, they're not gonna pay, period. So now we have to deal with the patient. That's why you have to tell the patient ahead of time. Remember, when they register and when they have the procedure, this procedure is not covered by your insurance company. So you have two options. Or you don't get the procedure, or you have to assume the financial costs of the procedure. That's how it works. Because if you submit the claim, remember, you're not going to get paid. It was not covered by your insurance. Where are you sending it? It's like you got an item and it has no guarantee. Where are you going to send it back to the place when you purchase, or to be repaired? And it says, oh no, I assume that it has guarantee on this. No, if you don't have a proof that you have a guarantee for how long is it, and you have the receipt that you purchased this item from this particular, you can't just claim or reassure yourself that you're going to get services. So that's basically what it is. Rejection errors. Now, rejection errors is different, because here you can correct these errors and you can resubmit your claim again. So you review it and then resubmit it. That's a different issue. This happens. There's always little things here and there, but that's not a big issue versus, services that are not covered by the insurance. It will be rejected, it will be denied. And when a claim is denied, remember, if it is rejected, rejection and denial are two different things. Denial means you have to apply for an appeal. It's been denied. We're not going to pay you. Now you're going to appeal the case. Rejections means there was something missing. Something was not complete. There was errors within the claim. So still have the chance to make the corrections and resubmit the claim. If after you do that correction, resubmit the claim, they find something that's not, you're not in compliant with the claim, then they can reject it. But at this point, you still have the chance to get paid for those services. Now, with non-covered services, that's another problem. Not only that those services are not covered by the insurance, and you still did it anyways, because you didn't verify, or you weren't aware of those things because you were a doctor, but someone else is supposed to be telling you. Someone is supposed to be getting, the pre-approval. Or you didn't check the insurance that you didn't have coverage for that particular day. Remember, verifying the insurance is a must every single time the patient comes in. Remember, this is what's going to happen if you submit the claim and that patient did not have coverage for that particular time that you received the services. We are not going to be paid, and the patient is going to be billed for it. And we're going to be in trouble because we did not do what we're supposed to do, which is check, verify that the patient's eligibility for that day of services was covered. See, we're going back again with 17. Appealing a denied claim. Remember, we only appeal when has been denied. It has been rejected. It is being rejected because there were some type of errors submissions, or because there was a need for adding, supporting documentation. So it's not being denied. Now, deny now, that's it. They're not gonna pay for those particular, claims. So here, the remittance advice, as I explained you before, is gonna stay that. See, the remittance advice, remember, this is the statement that the medical doctor is gonna receive after you submit the claim, whether you get paid or whether you did not get paid for some services or for all services altogether. So this document, this statement that the provider receives, which is called the remittance advice, is going to indicate that payment was denied for the following reasons. So the reasons are not processing error, remember, because then it will be rejected instead. So in this case, patient is not going to get paid. Oh, I'm sorry, the doctor or the hospital is not going to be paid because something else happens. So that's it. You're not going to get paid if you appeal because it was denied. So let's cover what are the causes for a claim denial. So that's the most important thing. So we cannot make the same mistakes again. Find out why. See, to appeal an insurance claim denial, you can do the following. So the first thing that you're gonna do is what happened? What was the problem with the claim? Ask your insurance provider to explain why your claim was denied in writing. So this was in the time when they were using paper-based. Okay, your claim is being denied. Now, electronically, remember, the patient, the medical provider or the hospital is going to receive, the remittance advice. There is going to be explained. Now, You're going to try to fight this because you're going to appeal this because it was denied, right? You got to review your policies, check your policy to see if you should be covered. So the first thing that you have to do, check if these services were covered by this particular policy, by this particular insurance. Remember, those are the first things that we have to do, and that's exactly what we've been talking about. If you didn't have coverage or the insurance doesn't cover for those services, you're not gonna get paid. It doesn't matter what you do. It's just that you're not gonna get paid. You're gonna gather information, collect relevant information and documentations to support your claim. Now, if there was something, that you encountered that is necessary for the insurance to know, said, oh no, listen to me. I have this documentation. I have this pre-authorization. I don't know how you did not have it, but it was pre-authorized. So now I have a reason. Remember, you always have to, attach documentations to support your claim. If you don't, it doesn't matter what you write down. It doesn't matter. You have to prove it to me. And how you prove it? Showing me documentations that attest that, these services should get paid. And file an appeal. It was denied. You got all this information to then the services were covered and so on and so forth. Now they still denying that claim. Now we're going to have an appeal. So you're going to file an internal appeal with your insurance company within the appeals timeline. Now you have a time frame in which you should appeal for the case. You can't just let it go. I'm telling you, when it comes to financials, they do it right away. They are on top of this. So someone has to be, someone has to make sure that, these claims get paid, that we have these accounts receivable paid. Wait for a response from who? The insurance company, of course. You appeal. You send them documentation, send them a letter, requesting for a review of that claim and the reasons why you think that, it was unfair not paying for those services. So they're going to read it, they're going to read the supporting documentation. And if they find the supporting documentation not valid or not legit or doesn't meet the criteria for the insurance company, well, that's it. After you appeal and you get denied, you just leave it there. There's no way that you're going to win that case. So that's how it works. Then request an external review. Yeah, that's part of the appeal process, but if it was denied, believe me, don't waste more time and money trying to fix this because it will not get paid. That's why, to prevent all this, we have to complete those forms accurately. Now, one of the things that happens because of these issues about claims not, rejected or denied is that back in the days they were using, people who were not trained appropriately on this field. So just hire someone, anyone, including medical assistants with us to fill out those claims. Because they didn't want to pay money, right, to a professional billing and coding. Because you have to pay separate money. Now they use the medical assistant to do everything. So they were having a lot of problems. Now you have to be certified biller and coder in order for you to, to work on this. Just being a medical assistant do not qualify because you're going to have all these issues. So that's how it works. So if it is denied, I'm sorry, So this will be the steps to appeal a denial. Procedure and services should be reviewed from original documents for diagnostic supporting documentation. That's what I've been saying all this time. I just covered all that stuff. So what was the reason that it was denied? Oh, for this reason. Oh, well, we're going to get all the supporting documentation. And again, still probably not going to do any well, because most of the time when the procedures are complex, meaning that they are expensive, you have to prove a necessity or documentation. You have to submit documentation with, explaining the necessity for those. And that's supposed to be done prior, not after. So that's basically what it is. So if you want to kind of avoid all these problems with denials and more likely denials of your claim, well, you have to get the pre-authorization or read the manual from the insurance company and see what is it that they pay. This is the job of the billing department, to verify whether these particular services actually covered by this policyholder. Is it covered? And how much is it covered? Some of the time, remember, these procedures are very complex. It might require a second surgical procedure after the first one. Well, the insurance might pay for the first one, not for the second, or the third if it is needed. So you have to verify. So otherwise, not gonna get paid. So you have to review the insurance policy. What is it that is covered? It's like when you have a car insurance and you got into an accident. Oh no, I'm covered. Well, is that what your insurance actually, that's the policy that you purchase, that it covers liability for every single thing? And what is the amount that you're gonna receive for each of, these liability issues? So it's not, yeah, they're gonna pay you, but they're gonna pay you $1,000, $10,000, $50,000, $200,000, $1 million. No, you have it for $20,000, but the damage is more than that. So then the rest, what are you gonna do? You're not gonna assume that everything is gonna be covered. Determine if condition is pre-existing. Now, pre-existing conditions are conditions that the patient had prior to enroll themselves to the new insurance company. Remember, back in the days, we have a lot of problems with insurance companies, as I explained it to you already, that they were increasing the premium of your insurance if you have a pre-existing condition versus someone who didn't have any medical conditions. So the premiums were excessively charged for someone who has a pre-existing condition. And some of the policies were explicit there and explain that if you have a pre-existing condition, you will have to pay from your pocket. Then the doctor will not gonna get reimbursed. The doctor has to bill the patient. Or it was incorrect diagnosis code was submitted with the original claim. Now, in this case, you're just gonna correct that. But most of the time, it's not that simple. Most of the time, it's just the insurance did not cover those services. So that's the major drawback from these appeals, because usually 95, 98, 98%, you will not win an appeal. Because that's what's happening. Non-covered benefits, we go back again. You will be and you will lose your case if it was not covered. There is no way that if a service that was not covered, you're going to get paid for it. You can resubmit it, you can add this, you can. If the services were not covered, sorry, you will not get paid. Period. Termination of coverage. Contact the patient. Remember, that is a problem, and it is highlighted right there because I told you from the beginning, the problem number one is not verifying that the patient has coverage for that particular day of service. If you don't have service, you have a card, you have an insurance card, that doesn't mean anything. Do you have insurance? Yes. What insurance is it? Oh, I have this. Okay, good. No, that's not how you verify. Can I have your insurance card? And you go there in the system or whatever other systems you have, because there are little machines there, like the one that you verify the credit cards and the debit cards, whether you are covered, whether you have enough balance to pay or not. There are certain machines that works like that for certain insurances. So you just slide the card or you just tap the card over there, and then it will tell you immediately. And they give you a proof, a receipt, whether you have coverage for the particular day or not. Remember, having coverage, do not get it twisted, is that the patient did not have insurance at that particular time. They have coverage. Their insurance was suspended. They didn't have coverage. They have a card, but it doesn't. It's like when you have a card, but it is expired. Yeah, I can have a credit card, debit card, but it's expired and it's not good. Or any other type of card, your Metro card. If it is expired, it's not going to go through. So the same goes for the patient's insurance benefits. And that's what we have to verify every single time. I'm telling you, because for this reason, you can get fired on the spot. Many people just procrastinate. Now you get fired if you didn't, verify the insurance company from the patient whether it has coverage or not for the particular day, because sometimes the patient does have, but it doesn't imply that every single patient is going to have. Well, you get away with that the first day or the second time, but you keep on doing it with all your patients. One of those patients is not going to have coverage. They're going to come over. The patient knows. They know that they don't have coverage. They just come and they know that you are not verifying. So they just pass the card, said, no, I'm going to go get the services. And if they send me the bill, I'm not going to pay, because the fault is the person who did not verify. And they win the case because they're not obliged to pay because you failed to get, to verify coverage. So that's basically what it is. So that's the most important thing. So don't think about anything else. Or you need to look for pre-approval before you order or do that test. It happens all the time. And I'm telling you, if you make a mistake like this, the patient comes, they make a scene, they find out who was the person who registered that patient that particular day of the visit, and then when they send the patient's bill, then it's going to come and say, oh, I came this day, and you're going to be there. So you will be the one who's going to be paying the consequences. So they're not going to deduct it from your money. They're just going to fire you because you're not good for that job. Okay, so that will be termination of coverage. Steps to appealing a failure to obtain pre-authorization. I mentioned it already. If you don't get the pre-authorization, that's it. You don't. There is no documentation to prove necessity that it's going to work. You didn't have no coverage, you're not going to get paid. Denied. You didn't get the pre-authorization before you did the procedure. Denied. So it doesn't matter what you do. I'm telling you, that money will not come. to the office. It will be denied. Remember, errors, omissions, that is a rejection. So for the rejection, you can resubmit. But when there is a denial, once again, maybe 1% all the time, you will get one of the claims, paid. But most of the time, it's not. So make sure that you do what you're supposed to. Out of network providers, that's another thing. Now, out of network, remember, is a non-participating provider that you're gonna go see. If you go see someone out of your network, someone that a medical professional that is not in your insurance as part of the insurance directory participant, your insurance can deny. Said, no, I'm not going to pay for those services. You were supposed to get someone from the network. Oh, no, but I have someone that I know from before. Well, sorry to tell you, but you're not covered. And you have to pay the provider for those services because you chose to pick up the medical provider. So that's basically how it works. Now, the medical providers are aware of this situation. When you have someone who has insurance, so then you have to get, all the means, all the details. That's why we recheck patients' insurance. And then it's how we find out that these insurance are not participating with these providers. So now you have to explain to the patient, hey, you're choosing a service from a provider that is not covered for your insurance. Do you know that you have the risk of having to pay for the services? Guess what the patient says? Oh, not a problem. Oh, they're going to pay. So then you get in trouble because you are the one who's going to provide the services. So if you don't get paid, now you have to bill the patient. Now you're going to get into a battle with the patient. So make sure that you do everything in your power to get all these done, clarifications to the patient, explanations. And remember, you're not the billing person, but the person who do the billing, at the time of the visit, someone in the office, they have to make them responsible for it. Provide letter of appeal explaining why higher levels of care was required. Remember, necessity. Here is these arguments that the medical office are, using to get paid. But it doesn't work. Believe me, it doesn't matter what much supporting information you provided. If you did not have coverage for those services, you're not going to get paid, period. But remember, this is the appeal. Think about someone who was convicted already to 5, 10 years of prison. The defendant's attorney is going to appeal, but it doesn't mean that they're going to win the case. The appeal most likely is to reduce the sentence, not to withdraw from, to dismiss the case. That is too late now. So the same happens with these claims. If you didn't file all the documentation, you didn't do all the due diligence prior to completing or accepting the benefits, then you're in trouble. So that's basically what it is. So you have to add all the supporting documentation, might be the patient's medical record, parts of, the diagnosis, the encounter form, services provided. Most of the time, medical doctor has to do a write-off or bill the patient and try to get anything from the patient if any money can be, credit in collections. Now we're gonna move to a different part of these claims. So how we are going to, prevent these claims from being, denied or rejected. So that's basically what it is. And we go back again to the same things because remember, this is a cycle. Everything, one thing leads to another thing, and usually are the same issues all together. That are the cause of, the denials of these claims. So that's basically what it is. Now, delinquent claims and prevention. A claim is considered delinquent if it is not being paid within 30 days of the day it was rendered or submitted. 30 days. That's why we have to keep on track the status of that claim. If we don't, then verify health insurance cards. Remember, we do that, and I mentioned 100 times, because this is something that you are going to be doing, verifying the insurance, the patient's insurance cards to make sure that, they have coverage. Because if you don't, then that is the reason why there is a delay for these claims to be paid or to move to the next cycle process. Determine each patient coverage. Now, again, go to the same things that we have been discussed here. Why these claims are delinquent. Remember, delinquent is because they have not met certain criteria. So that's basically how it works. So you have to contact the insurance company or, by phone or by email or by any other means to make sure, because your billing department is gonna try to do their best to get the money, even though if they know that they're not gonna get it. They're gonna resubmit the claims, more documentations to prove coverage, to prove a necessity. But if there is something there that, you're not gonna bypass, that you failed to meet a very important requirement, so then it's not gonna be paid. I'm telling you, very, very seldom the billing department wins an appeal. So that's better to prevent by collecting all the information from the beginning, getting all the data needed, all the pre-authorizations first, making sure that the patient has coverage for the particular day or that the insurance policy covers for those services. Remember, that is totally different. That you didn't verify that the insurance had expired or didn't have coverage for that day versus the insurance does not cover those services, even though if you have your insurance active. That's a different issue. There are two different situations. So make sure that that's not your fault as a medical assistant. Your fault is not verifying the insurance card. That's it. That's your fault because that's something that you have to do every single time a patient comes to your office for a visit to meet with the doctor. The other one is the billing department. They had to make sure that they know that this particular policy cover or does not cover these services before the services are provided. And it has to notify the medical doctor. So we have those policies in place. So whenever we're gonna do a procedure, we know we have a manual and we're gonna go see it says, this procedure is not covered by this particular insurance. So patient needs to have other options. Or you pay for it or you don't get it. So that's basically what it is. Contact payer to verify received claim because we need to verify what's going on with status. Remember, review records to determine if claim is paid, denied, or pending. Go back again to the same thing. And if there is some issues there regarding, documentation that needs to be submitted, then submit that supporting documentation. But other than that, it's not actually happening because they have most of the information. It doesn't matter what other information you send. When they say that is denied, clean claim, we talk about this. So this is something that is only talking about the clean claim. Remember, these are the insurance claims that have been submitted and they are complete. They have no errors. They have no issues. Everything was met. You did the pre-certification, the patient has coverage, the insurance policy of the patient covers that particular procedure, you have attached supporting documentation, so you got everything. So now this claim is an adjudication goes to the insurance that is going to pay for these services. That's it. So if he has no issues, you're not going to have no problems with delays, denials, or else. So that's the beauty of, having a clean claim. We wish every single claim were clean, but unfortunately, it's not that way. Key points about clean claims, meaning what is it that we have to do to, have a claim that is not going to be denied, it's not going to be rejected. Information accuracy, all the information that it is entered in that claim has to be accurate. That's it. Patient demographic, all the information from the patient has to be there. Whatever is required, and it has to be accurate. Remember, accuracy sometimes fails when you do not update the patient's information in the files. Patient comes in today, you didn't verify that the patient has changed address, that the patient has a different phone number, a different email, or different insurance card. Remember, we have, like anything else, we change things. That the medical providers have entered the correct codes for diagnosis, not the medical provider, but the billing department for the procedures, for the evaluation and management services. So that is important. It's accurate, no omissions, complete documentations, everything that is needed to support these procedures, treatments, all the documentation, it is attached to these claims. Compliance with guidelines, follow all payer-specific rules and coding standards. Remember, you have to do what your payer, the person that is going to pay your bills, you have to meet the requirements. If you don't, then is when you encounter all these issues. So that's basically what it is. So you need to be familiar with their policies first. You have to submit them in a timely fashion. Remember, if you don't, then you're going to lose the opportunity of claiming those services or being reimbursed. Remember, you have certain periods of time in which you're supposed to submit these claims. That's why that claims, the maximum of time that we take to submit these claims is like 2 weeks. Some people, some offices, they submit these claims weekly, maximum bi-weekly. They don't let it pass by because otherwise you can end up in the situation that you're going to meet, that you're going to fail the deadline. And that is not good because that will be a denial of the claim. That's it. The expiration date has passed. So I'm sorry, timelines have passed. We're not taking your claim anymore. So that's how actually works. So gotta make sure that we do the right thing. Fortunately, you're not gonna be working in a billing department, but if you do, then you have to get a certificate as a billing coder. But if you don't, just gonna do whatever is pertaining to you as a medical assistant if you work for a doctor's office. Remember, once again, only the students that are working for doctor's offices are gonna be encountering some of these situations with insurance, because you have to at least register the patients when they are new, check insurance, and verify that the patients have coverage for that particular day. You're going to be receiving co-payments. You're going to be doing referrals. Now, if you work in a hospital, you don't have to do any of this. So you're just going to do your clinical things. But most of the jobs for the new grads as medical assistants are like 60% in doctor's offices or small practices, clinics. That's how it works. So for that reason, you need to be familiar with this. Any questions about processing a health insurance claim? Okay, so we're moving on. We're gonna continue with the next chapter. The next chapter, we're gonna talk about now Medicare. Then we're gonna talk about Medicaid. Then after that, we're gonna talk about workers' compensation. And after that, we're gonna go on vacation. So just to relax a little bit from all these subjects, right? And come fresh next year, ready to complete this program, right? That's what we're gonna do. Nobody says yes, professor. Supposed to say yes. That's how it works. Okay, so let me see what is my other points. So this is close this, save, and then oh, here's my oh Medicare. So let's go back here to here we have it. Okay, so we are going to continue now with Medicare. So you heard about Medicare, you know some stuff about Medicare. Some other stuff that you don't, we're gonna discuss it right here. It's a lot of stuff that we're gonna talk about Medicare, but are you gonna need all of this for the exam? No. Are you gonna need to know about Medicare on the long run for you, your own benefits? Yes. Because one way or another, if you reach the age of 65, something else happens to you, then you might be eligible to apply for Medicare coverage. So it is important for everyone, particularly if you work in this country or if you reach the age of 65 and you go on retirement. So let's talk about Medicare. Do not mix up Medicare with Medicaid because it's totally different. So what's going on with Medicare? So think about this. This is a governmental agency. How many people work? 60 something % of people get insurance through group insurance, through their employer. So for that reason, Medicare is the largest single medical benefit program in the United States. It's not Oxford, it's not Blue Cross Blue Shield. No, it's Medicare. Because everyone who works out the 60%, think about 60%, are going to receive Medicare services plus other conditions that the patient have before they reach the age of 65 can qualify to get Medicare. So we're going to talk about that. So who controls this? Well, remember, this is a government, or, this is paid, funded by the government because this is from the taxpayers. If you work, then your employer is going to deduct taxes, a lot of taxes. And one of them is for Medicare. Why? Because later on, when you retire, you're going to get services from Medicare. So you pay them in advance. It's not just you, but your spouse can also benefit from this when you receive your retirement. Now, retirement at the full age, which is 65 as of today, that can change. If you retire at 62, you're not going to get it because it's after 65, remember. So pay attention to all those things, that this is very important. So the government gives you the funds to the medical entities to reimburse the patients for services through Medicare. But who controls this? Who administers this this money that it is, distributed to the clients? The Center for Medicare and Medicaid Services. That's why we talk about that form CMS, because that's the form that, the Centers for Medicare and Medicaid Services utilizes, the most common for services for most of the people that receives money from the government. Not money from the government, insurance funded by the government. So that's basically what it is. So the CMS is responsible for the operations of the Medicare program and selected Medicare administrative contractors. So Medicare has contractors, has an agency that is called the MCA, Medicare Administrative Contractors. They are the ones who actually sign the contract with the providers. So if I'm a provider and I want to receive patients or clients from Medicare, then I have to sign a contract with these particular organizations, the MCA organization or program. They are going to process all the claims for the services of these Medicare patients, whether it's Part A, Part B, or Part D, or remember, Part C is not included here as something that the Medicare is going to pay. And the DME, which is the durable medical equipment. Remember, we talk about equipment that sometimes is provided, whether rented or given to the patient, somebody has to pay for it. For ambulance services, those services are not provided by the regular codes from the CPT. Therefore, in certain organizations, we need this to be covered. So we're going to see all that and more. So Medicare pays for services Part A and Part B. Remember, everything else, Part C and Part D, these are addendums. These are other insurances that you're going to buy separate so you can get covered. So that's basically how it works. So keep in mind that, Medicare is a little complicated. So it's not like, oh, I have Medicare, so I got everything. No, you get certain things that you might be covered, others you might not. And if you did not work for a certain period of time, which is 10 years, and pay taxes for a period of 10 years, you're not entitled for Medicare at the retirement. Now, you can qualify in other ways, but not for this reason, unless you are the spouse of someone who worked. So we will talk about that as we move on. So parts of Medicare. Now think about this. Do not confuse parts of Medicare with the parts of Medicare that you actually get covered by Medicare. Because Medicare has 4 parts, but are all these parts covered by Medicare? No. You have to have a supplementary insurance that is going to pay for Part C and sometimes for Part D, which are drugs, medications. But Part A and Part B are covered by Medicare. So here is Part A. Remember, you need to know what Part A covers, what Part B covers, what Part D covers. This is very important because these are questions for exams. Part A pays for all the services in the hospital if you are admitted to a hospital, hospitalizations. You are there for more than 24 hours, you've been admitted to a hospital, the hospital is going to be responsible for those payments. Medicare is going to be responsible for those payments. So that's how it works. So Medicare reimburses the medical providers for the services provided when you are hospitalized, if you are a policyholder or Medicaid. So here it says which institution, which services are actually covered. Inpatient hospital critical care access. You are sick, very sick, so you were sent to the CCU, the ICU, I'm sorry, the intensive care unit. That's it. You there. Medicare, if you are Medicare policyholder, you're gonna get paid for the services. Now remember, just because it says hospital insurance does not imply that anytime that you go to the hospital, Medicare is gonna pay for it. That's not how it works. You have to be hospitalized. Remember, hospitals also have outpatient clinics. You have to be inpatient. Other institutions that covers Medicare. Skilled nursing facility. Oh, what is that? Skilled nursing facility is when you're going to receive care from doctors and nurses. For instance, we have some examples here: physical, occupational, and speech therapy. You got into an accident, okay, you're not going to be able to move. By the time you know that you're going to get better, then you're going to be put into these rehab centers. That is going to be covered. Occupational. Remember, occupational means it happens in your job. It's something that you needed to do your job. So that is occupational. Speech therapy. You got into an accident, you're not able to talk, you can, well, then just like physical therapy, you're going to stay there and this insurance is going to pay for it. Wound care, because you work with nurses and nurses are the ones who do the wound care. So right here, you're going to be taking care from these professionals in one of these skilled nursing facilities while you being treated. Intravenous therapy. You need therapy through Your veins, you need IV fluids with medications, you need to come and be hospitalized or be in those nursing home facilities. Well, that is also paid by Medicare Part A. A hospice. Remember, hospice is a place when terminally ill patients are going to end up. You have no, there's no treatments for you anymore. You have a terminally illness. It doesn't matter what we do, nothing is going to happen, nothing is going to change. You have certain time, you know, a sort of kind of, surviving period. You have 1 month, 3 months, 6 months, maybe a year to live. So then you're going to be sent to those hospice care. If your family wants to send you to these places, if you have someone at home, then they're going to send a nurse to be taking care of you. Somebody else is going to be taking care of you. All depends. So that's basically what it is. So we will discuss this. Some home healthcare. Because remember, if you don't want to go to a hospice, your family don't want to send you to a hospice, they want to keep you at home, then home care. They will pay someone to take care of you, and that will be covered by Medicare Part A. It's just that you didn't want to be admitted. Instead, you want to be at home. That's what your family decided. If you don't have someone to take care of you, you end up in a hospice. Because somebody has to render services to you. So that's basically what it is. Later on, we will discuss a little bit more about hospice, because a couple of questions from there might arise on your exam. So we will cover those. Okay, so this will be part A. Remember, so the only thing that you need to remember is not all these institutions where you are being qualified for receiving services and services that are going to be paid by Medicaid. What you need to remember is part A covers inpatient hospitalizations. That is it. That's all you need to know about part A. Now let's talk about part B. Part B covers all the services rendered in an outpatient setting. If you go to your doctors, to the PCP, you do not stay there, just receive services from them, like in the following example. Provider services, your PCP. This is an outpatient hospital care. Or remember, provider services means the doctor's office. Outpatient hospital care, because this is your PCP that works in hospitals. It's not that you're hospitalized. No, this is the outpatient clinic. Durable medical equipment, it will be also covered for these patients. If you need a wheelchair, if you need some other equipment, here we go, it's going to be paid. Anything else that you might need? Remember, if certain services that are not covered by Medicare Part A, like home health care, sometimes, the situation is not that the patient has a terminal illness. It might be that just the patient don't want to go to a nursing home. For that reason, family wants to keep them at home, but he or she, qualifies for those services. Then if Medicare doesn't pay, then Part A doesn't cover, then Part B is going to cover that part. Then, it was not covered by the Part A. So that's basically what it is. This Part B also covered for all these preventive services. Remember, preventive services are things that are assisting or helping the patient to maintain, good state of health. What are the maintenance? Vaccinations. You need vaccines, that's preventive. You need a colonoscopy, that is preventive. You need a mammography, that is preventive. You need a pap smear, that is preventive. So that's basically what it is. There are some tests that are required because we are going to prevent, not that we're going to prevent from that happening, but we are going to be, on the lookout that something is not going to happen later on in certain, uh, ages based on the age of the patient or the conditions in certain situations. Remember when was the pandemic? Immediately all these vaccines were a preventive measurement and it was used for everyone who wants to be vaccinated. Mammographers are there and your insurance pays for it. Colonoscopies, your insurance pays for it. And many other tests that are required as a preventive, service. So we're going to run them and we're going to write down on the encounter form and the medical records. This is a preventive service. And they know that they cover it. For any insurance, we do it, but we're talking about Part B. So what is it that you need to know about Part B, for example? That this is the part of the insurance, the part of the Medicare that pay for services in an outpatient ambulatory settings. That's it. The other one is hospitalized patient, admitted patients. Part A, Part B, just for regular, visits. You are not that sick, but you are following your routine care with your primary care physician, whether in a hospital or in a clinic, whatever the case may be. Any questions about Part A and Part B of Medicare? Well, after there, I believe that everybody should be fine. So just don't forget the difference between Part A and Part B. Don't mix them up when you're answering the questions, because then, very simple questions can cause you not to do well on your exam. Let's talk about Part C. Remember, there are 4 parts on Medicare, but not all of them are covered by Medicare. So be careful with that, because that's something that people do not understand. You said, oh, I have 4 parts. They pay for it if I get sick, if I get hospitalized, they pay for it. If I have to do my regular checkups with my doctor, my services, they pay for it. If I need medications, they pay for it. Yes and no. There's little, issues in between that you need to understand. Now, Medicare Advantage Part C. See, Medicare Advantage. This is an additional insurance that you can purchase from Medicare. That's a different issue. So it's not covered by, the money that you pay during your workplace, your work time. It was not deducted, Part C. So now Medicare is going to tell you, okay, so you have retired already, right? So now you get Part A, Part B. Now, if you want more services, then that are not covered by Medicare, we're going to talk about those services that are not covered. And then you have to have another insurance. If you, we sell it to you. We have the cheaper brands. That's the Part C, which is called the Medicare Advantage. That's basically. And you hear there are commercials on TV all the time talking about Medicare Advantage. That's Part C that they're talking about. So Medicare offers health plans options run by Medicare-approved private insurance company, managed care HMOs or PPOs. You can encounter in all types of insurances, whether you have a private insurance, whether you have a government insurance, all of them offers the option. Because remember, it depends on where you get it from. If you get it from the government, well, you get a cheaper price, but less coverage. If you get it for the private, which is a PPO, then you're gonna pay a higher premium for your Medicare Advantage, but it covers more services. So that's basically what it is. So if you have that, that is gonna be like, an system to Part A and Part B of your Medicare, because there are some services that are not going to be covered by Medicare, and having this extra, this optional Medicare Advantage of Part C, now you're going to get those services that otherwise you would not receive from Medicare. So that's basically what it is. Now it says right here, it requires more coverage for dental, vision. See, now these are things that usually Medicare Part A and Part B do not cover. Dental, vision, but now we're talking about vision or hearing aids. So they're talking about glasses. They're talking about these hearing aid devices for someone who is, has problems with hearing. They're not covered. Part C will, Medicare directly will not. Prescription glasses or drugs, there are certain medications that are not covered by Medicare. So Part C will play that role. So that's basically what it is. But it's not automatically include when you get your retirement. Those are options, but you have to pay for it. And you have to enroll, because they are not automatically part of it. Part A and Part B, they are, but the other ones, they are not. Part D, D for drugs, remember. So don't forget this, because this is the part of Medicare that helps cover the cost of prescription drugs. Or, they're gonna choose mostly the medications that are more affordable to you. And which medications are more affordable to you? Well, if you have a generic brand of that if you have a generic medication from that brand, then that's what the Medicaid or Medicare is going to pay. Because Medicaid and Medicare, they pay for medications, mostly the ones that are generic. When we get to pharmacology, we're going to talk about what is generic. What is brand medications? Why brand medications cost more? What generic costs less? And we're going to clarify that, dilemma, so to speak, people saying, oh, if it is generic, it's not good. Well, we're going to clarify how true is that. That, for me, is like a myth. People always talk about things that they don't know. So again, we will discuss that when we get there. But this Part D covers medications, drugs. They get better prices, better coverage, but they usually use all these generic medications if there is a generic medication. And if they don't have a generic medication, they have the brand medication, then they will get it for a cheaper price. So it is an advantage to you, or to the client, of course. So that's basically what it is. Remember, these policyholders of Medicare that has Part D, usually they have an extra card that is a prescription drug discount, and that's the one that they show to the pharmacists. They said, "Oh, I have a prescription discount." Then they show us like a coupon that this is a little card that they receive. This is like other advantage that they have from Medicare. It's like, you don't have to pay the full fare when you take public transportation. So that's part of it. So you have lots of advantage, just that you need to use them wisely. And you need to understand how that works. So that will be part D. So remember, Medicare has 4 parts: A, B, C, and D. But remember, D does not cover all the medications. And in order for you to cover all that in some of your medical services or devices, you have to add the Medicare Advantage, which is Part C. It is not included. You have to pay. It is optional if you want it or not. If you don't want it, then you have to pay for your glasses. You have to pay for your hearing aids. You have to pay for certain medications that are not covered by Medicare. So that's how it works. Any questions about these 4 parts of Medicare? So you need to know the 4 parts, remember. You need to know what each of them consists of. What is it that they cover? Because that's something that you might see on your exam. Let's talk about now Medicare eligibility. Who qualifies? That's basically what it is. So again, as I mentioned before, here is the criteria for someone who is qualified or eligible to receive Medicare. Individuals or their spouses must have worked at least 10 years in a Medicare covered employment. That's basic. So you work for this company, they deduct from your paycheck Medicare. So you will earn at least 10 years. So you earn some amount of credits. Now, if you don't work, but your spouse does, and it meets that requirement of 10 years and pay Medicare, then you will qualify also. But you will qualify when you reach an age of 65. You have to be 65 in order for you to qualify. Now, I know some of you are thinking, oh, but I've seen someone that is younger than 65 has Medicare. Well, we will discuss that. Those are special situations. And we're going to discuss who qualifies for those. For Medicare who has not reached the age of 65. Now, what is another requirement? The person that not only paid for it, but if you are not citizen or have permanent residence in the United States, at the end of the time, you will not qualify for it. So you have to be a citizen or a permanent resident of this country in order for you to qualify. Now, I'm mentioning this because there are lots of, undocumented people who pay taxes. They are not illegal in this country, but they pay taxes with some type of ID that they get. They will not qualify. If they do not clear their status, immigration status in this country, they will not qualify. They will pay and they will be deducted for Medicare, but they will not qualify to get the services because you have to meet these criteria to be a citizen or at least permanent resident of this country. So these are things that help, particularly in my case, because I know a lot of people that, I'm not from here, but in my case, I'm not talking about personally, but I'm legal in this country. But I know a lot of people who are not, because most of the people, they were born here, or they are citizens and they don't have family in other countries. Well, they don't know this, but it is interesting and important that we understand this. Some people have the misconception that because they are paying taxes, but they don't have a work permit, they don't have a legal ID to, pay taxes or something like that. Those taxes are lost. That money is just taken away from you. And if you never legalize yourself, then you will not be able to utilize that money that you pay. After you do so, yes, you can claim those um, pay taxes um, and change your status, and that will be added to to you. So that's basically how it works. All right. So, any questions about Medicare eligibility up to now? So think about this, because these are the questions for the exam. Who qualifies for Medicare? So immediately you said someone who is 65 or older. That is it. It's not that they're going to tell you, oh, someone who has worked more than 10 years and is qualified and is resident. It's no. It's simple questions. How many parts the Medicare has? 4. Which ones are? Part A, Part B, Part C. What is Part B? Part A covers hospitalization. What is Part B? Part B covers outpatients clinics. What is Part D? Drugs. Usually they don't ask you about Part C because this is an extra, an optional insurance paid hospice by Medicare. So they don't ask about Part C. But if they ask about how many parts, you have to include Part C. It's A, B, C, indeed. Part D, medications, drugs. So that's basically what it is. So 65 and older, don't mix it up, because Medicaid pay at any age from birth until you no longer exist in this country, in this world. So that's a different issue. So those are the basics that I want you to understand, not the details, because that's not going to help you. So Medicare Part A coverage 65 years or older are already receiving retirement benefits from Social Security benefits. Remember, this goes back to the prior slide, right? When it says that you have to be 65, you have to work with an employment that you pay taxes. Taxes for Medicare were deducted, and you work more than 10 years. So you're already receiving retirement or not. Because after 65, you decide to retire or not. This is up to you. You can still keep on working, but you have Medicare services, so you can use it, even though if you have not retired. If you retire, perfect. You're going to get your full retirement, your full coverage. But if you still want to keep on working after 65, you can do it. You still receive Medicare, but then you're going to have insurance from your job still. So then that insurance is going to be the primary one. Remember, your group insurance, your employer insurance is going to be the primary one always. You're not working and you have Medicare, Medicaid. What's going to be the primary? Medicare. Medicaid is the last resort. So Medicare is the last one that's going to pay. So if you don't have anything else but Medicaid, well, Medicaid pay for it. But if you have a private insurance through your job, you have group insurance plus Medicaid, which one is the principal or the who pays first? Your job. Your insurance from your job pays first. That's your primary insurance. Your Medicaid or Medicare will be secondary. And if you don't have this job's insurance, but you have a Medicare and Medicaid, Medicare price is the principal one. Prime and Medicaid is the last. Medicaid always the last. So that's how it works. So you need to understand how do we build the patients, because these are things that needs to be understood. Eligible to receive Social Security benefits but have not yet filed for them. That explains the second part. You already retired, you got your full benefits from Medicaid Part A because you're 65, you already worked for more than 10 years, you receive your Medicare. You are eligible for Medicare because you meet the years. 65, your age, let's put it that way. But you don't want to retire yet. You still receive Medicare if you apply for it. But once again, your insurance from your work, because you're still working, is going to be your primary insurance. And Medicare is going to be your secondary. So those are the things that I want you to understand. Now, before we enter this part A, under age of 65, which is people that are qualified to get Medicare, not Medicaid, Medicare, and they have not reached the age of 65, they have not worked or anything, it doesn't matter. Someone who meets these criteria will get Medicaid. So when we come back, we're going to talk about this particular population that can receive Medicare, even though if you have not reached the age of 65. You can be at any age. You can be 1 month old, 2, 3 years old, 5 years old, 10 years old, 20 years old, 40 years old, any age. And you can get Medicare if you fall under this particular criteria. So we will discuss that when we get back from the break. Okay, so we're gonna get some minutes. We're gonna come back at 7:40, and we're gonna continue with this after that. Okay, so let's take a break. 7:40 it is. If you have any questions, you ask me when you come back. Other than that, we just gonna come back to the class and learn a little bit about this, because it's a very, very important subject for all of us, because one way or another, we are going to be involved with this Medicare. Okay, enjoy your break. See you 7:40. Take care.
Thank you.
Take care. Later. Okay, so we are back.
Yes, we're here. Thank you.
Good. So let's continue with this chapter. So Medicare, remember we're talking about Medicare Part A, Part B, Part C, Part D. Now Medicare Part A in certain specific situations. So keep in mind that Medicare is for people older than 65. Now, just keep in mind that not that they have worked 10 years, that's a little extra right there, because that's the qualifications, the eligibility for that. But there are other situations in which a patient, a client can actually receive benefits from Medicare, even though if they have not reached the age of 65. So let's just dip into that. Now, if someone has received Social Security or the RRB, which is the Railroad Retirement Board, this is for people who work in the railroad. That's basically what it is. And they got some conditions due to exposure to fumes, chemicals. So they develop sickness prior to reaching the age of 65. So that's basically what it's talking about. So whether you have Social Security or whether you have the Railroad Board retirement, you qualify, even though if you have not reached the age of 65. Now, what will be the conditions that actually qualifies you for that? That will be the end of stage renal disease patients, which we use the acronym ESRD. Remember, ESRD stands for end stage renal disease. This is someone who is their kidneys are not functioning and they are in dialysis, or they are in dialysis. They must have to be in dialysis, waiting for a kidney transplant. So that person can be of any age. They will qualify to receive Part A coverage under Medicare. So that's something that is an exception to the rule. Now, what is that? Because this person is disabled. This person is not able to work. This person has to receive dialysis 3 to 4 hours, 3 times per week. So 3-4 hours dialysis per day for 3 days in a week. What is it that you're going to be able to do? Nothing. So definitely you are considered disabled. In these circumstances, you will be granted, or you will be eligible to apply for Medicare Part A coverage. Remember, hospitalization. You can be hospitalized, you can be treated over there, and you can be waiting for your organ transplant or kidney transplant, so to speak. So that's basically how it works. So end-stage renal disease patients qualifies for Medicare. Think about that just in case you see a question in your exam, because these are one of those exceptions to the rule. Other than that, you have to meet, the eligibility criteria, which is being 65 years of age, have worked for 10 years and pay Medicare taxes. That's basically what it is. So let's continue with this Medicare eligibility information. Because remember, we need to keep certain information from our patients before they are eligible for it. So the standard method for providers to obtain Medicare eligibility information is through electronic data interchange. We talk about this. EDI stands for electronic data interchange. This is a software application that, medical organization, well, any company that uses electronic filing or in electronic information interchange can use. So we are going to, share the patient's information with other institutions. We have to have EDI. So that's basically what it is. So it can be done over the phone. It can be done in person. You go there and you qualify, you apply and fill an application. Well, it doesn't matter. But the best way, the easiest way to do this application, because it takes longer periods of time for you to apply and receive the results, just like when you submit a claim, you get a prompt answer. Well, with this filing of Medicare, electronically, it's going to be a lot faster than whether you do it over the phone or you apply in person or you go online and try to do something that you're not familiar with. So once again, that's how it works. Now, to do this, it is needed the provider's name and identification number. So the provider's name, which is called, we are not talking about the provider's, the provider's name, yeah, but the identification is not the license number from the medical provider. It's not the doctor's medical license. These medical providers who are, participants of Medicare, if you are the owner of your office, you're going to receive a number that is going to identify you as a Medicare provider or a provider for any other insurance organization. And that identification is called NPI, which stands for National Provider Identification. So when you complete, as we went over a little bit over the MS 1500 form for, the claim for submitting charges for services, at the end of this page, you can encounter the NPI, the name of the provider who provides the services, the ID from this provider, if he or she is the participant provider from any of the insurances, but in this case, we're talking about Medicare, so you will have a Medicare NPI number. Now, once again, you have to have one. You can't just make yourself one. You have to be participant provider in order for you. Hospitals have a different ID identification because it's not the provider. This is the organization in that case. And the insurance company has another identification number. So each one of them are going to identify these services as such. So that's basically what we're talking about here. So the medical provider is going to have an identification because it's a participating provider from that particular insurance, and that is called NPI. It's like 9 to 10 numbers. So that's basically what it is. And in order for us to verify that this medical provider actually is a participant, you just enter the directory of that particular insurance, type the doctor's name, or enter the NPI number. And if the patient name pops up, then it is a participant. If it doesn't, it's like when you use a ID or a passcode that is not the correct one, it's going to reject you and nothing is going to show up there. So it's going to have the last name, the first name, or initials. Remember the one that, is going to apply for this. The healthcare insurance claim number and the gender. So when we submit these claims, we have to put all this information, patient's information and the provider's information. Remember that the first 13 blocks are a CMA 1500 is information about the patient. And 14 to 33 is blocks are information that was collected by the medical doctor, belongs to the medical doctor, to the medical office. So that's basically. So the diagnosis, who gives diagnosis? The medical doctor. Who gives the codes for procedures? The medical doctor. Who's the NPI number? The medical doctor. So basically, that's exactly what's going on with this form. So you have to complete this form using all this information, because now this information is going to be sent to the insurance company, Medicare, and the Medicare is going to verify if this person or this provider is a participant and if the patient is a policy holder. So either or, we got to verify, because we might have a provider, but with a patient who does not have a Medicare or is not eligible, doesn't have the insurance. So either or, but you're still filing for them. So you got to make sure that you have the whole information there. So Medicare enrollment, how you gonna enroll to Medicare? Well, some of the people think that after they reach the age of 55, this enrollment is automatically. No, it's not. No, it is not. So you have to enroll yourself 3 months prior to the retirement age, which is or the time that you plan to apply for Medicare, which is 65. You have to do it 3 months earlier. I mean, you can do it before, but it's recommended to do it 3 months earlier, because remember, if you do it late, then you're not going to receive your benefits right away, because it's going to take a process for these claims to be adjudicated and, completed, so you can get a notification that you have been enrolled in this program. And if you retire at 65 and you apply a month prior, then you're going to be 2-3 months without insurance, without Medicare. So that's a fact. So it's a good thing that, you can do it. So there are 2 ways of doing this. Individuals are enrolled automatically. So again, it's not automatically. It's just that, you turn 65, so the doors are open. So is my registration is open for you to complete those forms, but you have to do it. It's not done. Okay, I'm 65, so automatically I have insurance. No, that is not true. So you have to do it. It is that, that registrations are open for you. You cannot do it prior to that. You can do it after, but then you're probably going to run into some penalties if you don't do it on time. Now, they can apply for Medicare coverage, remember, whether it is filing yourself or, part of the information is already done over there because you already pay some dues for this coverage, but it's not completely automatic. So it says right here, individuals older than 65 years old do not pay premium for Part A if they or their spouses have paid Medicare taxes while they were working. Of course, we pay them. You don't have to pay because we already pay. The money was already discounted from our salary every paycheck. Now, remember that one of the eligibilities for the receiving Medicare is that you work yourself or your spouse, whether it's the spouse, the wife, or the husband, either or. So that's basic. And you work more than 10 years and you pay your taxes. So that's basically how it is. Now, then you're going to have Part A, and you're not going to have, remember, those monthly payments because you already covered. But if you want Part C, that's a different issue we talk about. Automatic enrollment, look what the automatic, according to them, states. About 3 months before 65 birthday, because that's how it works, or the 24 months of disability if you've been disabled. Remember, sometimes you are disabled, you're not working, but you still have not reached the age of 65, or you are currently working, now you reach the age of 65. Either or, you can apply. Individuals are sent an initial enrollment package that contains information about Medicare, a questionnaire, and a Medicare card. Now, remember, this is the part that is not automatically. Yes, you're going to reach the age of 65. They send you a notification that a package, you can go to this location, to this place. That was back in the days when we didn't have this electronic filing. Then they send you a package through your mail, and then you have to enter all the information yourself. So it's not automatic. They send you the package, but if you didn't complete it or you don't complete it, then you're not going to be enrolled. Now it's done online. So you apply and then you complete all these forms online. That is basically what it is. But then if you don't complete, then it's not automatically. Automatically means I'm enrolled. Oh, I reached 65, I'm enrolled. I don't have to do anything. I'm just start receiving services. The card shows up in my mailbox and I just gonna use it. No, it doesn't happen. That is what is called automatic. This is like when you drive a car that is automatic. That's not automatic. That is semi-automatic because you have to do half of the maneuvers in order to drive your car. You don't have to change shift speeds or anything like that. It does it automatically, but you have to start your car. You have to put it on drive and you have to press the gas. So then it's not automatic. The same goes with this enrollment. That was back in the days that they send you a package. Now you have to open it up and complete the form. That's not the automatic, because if you don't complete it, so you're not gonna get the insurance. Whether it's online, whether it's manual, the package that they send it to you, because some people still receive the paper, application because they are not good with computers. Think about this: 65 old people not long ago, they weren't familiar with computers. So, and right at this time, there are people who don't feel comfortable with filling applications online because they don't know how to get access to a computer, how to go to this particular link, what else they're gonna do, what information, how to enter, how to save, and how to attach documents to it. So it creates a little hassle. So they want the paper, package in the receiving email. But once again, that's not considered automatic. Automatic means you get it without applying for it. You got 65 years of age, you already pay your dues because they know already you apply for your retirement, because you have to apply for your retirement. But automatic means you get it without doing anything because they know they have your information. But that's not the case. So that's basically how it is. You're going to complete some forms and you are going to send them, because when you receive that package is because you already are close to get your 65 years of age. So that basically, or you go online, you qualify to send your email. Okay, your retirement is getting close, so your information, you can complete this information in this particular link and you go there and they should do it. So that's how it works. Now, it says right there, if the individual wants both Medicare Part A and Part B, he or she signs the Medicare card and keeps in a safe place. Now, when you fill in that application, you have to check what parts of the Medicare you want to receive, because otherwise you're not going to get them. See, it's not automatic. Now, this is not like filling out an application for paying services. No, this is to receive the services from Medicare. Individuals who do not want Part B coverage because there is a monthly premium associated with it must follow the instructions that accompany the Medicare card. See, it's not automatic. And it's not true that you're going to get Part A, Part B, and Part D in your insurance coverage for Medicare. So there's lots of misinformation when you're actually doing this. Now you encounter yourself in a bunch of, mishaps. So that's basically how it is. So Medicare Part A, you qualify for it. That is for sure. But you have to complete the documents. Now you want Part B, you have to pay some extra. That's why sometimes you gotta get Part C. because Part B does not cover much, and Part A does not cover certain procedures, certain services. So you gotta get that. So that's basically how it works. So you're gonna just fill out the application, mark when it says Part A, Part B, whether you want it or not. But then you gotta make sure that you're gonna be paying extra premium for that. It's not include with all the taxes that you pay, the money that they deducted from you when you were working. So that is something that you have to take in consideration. So what exactly we're receiving? Not much. Not much. After all this money that they discount from you, you don't get much. Now, if you did not sign for Part A or Part B when you were first eligible, you can sign up during a general enrollment period. That is another type of, this is like another date, another policy for you to do it. That will begin in January, the 1st to March the 31st of each year. Remember, your day of birth for the 65 might not run into these months. If that happens, then you choose either or. You didn't enroll for some reasons, well, you have the chance to do it later on. But when you reach the 65, if you do not enroll, remember, you're going to be penalized for not enrolling when you were supposed to. So that's basically what it is. So you have some grace period. You got some time, extra time where you can sign without being penalized. But other than that, once again, all of these carries the burden that you have to pay more because you didn't do it on time. So again, it's not as as helpful or good as we probably thought about Medicare. So it doesn't cover much. So one of the one that we have is Part A. Part B is kind of non-existent because you have to pay more and you have to enroll individually for that. Part C, you have to buy optional insurance. Part D doesn't cover much. Certain medication doesn't cover, so you have to have the assistance of, Part C to get your medications or services that are not covered for Part A or Part B if you have Part B. So that's how it works. So look at here what it says, what I just mentioned it to you. Medicare Part A, Medicare pays only a portion of the patient's acute care and critical access to hospital and inpatient expenses. So it's going to pay a portion. It's not going to pay the whole thing. So one of the negotiations that Medicare has with the medical institution says that, hey, I'm going to pay this much and, the rest, the waive it because it's a government. So they got deals. I don't pay all the services. I charge $200 for it. You know how much Medicare pays? 80%. 80%. Everything else has to come out with the patient's pocket or the second insurance if they have the Medicare Advantage insurance. So that's the whole deal. So think about it. Not much, right? So once again, in order to kind of subsidize this problem, like kind of fix the problem, and not having the patient responsible for paying the balance, we're talking about Medicare. What they do is they have a negotiation with the institution. It says, I'm going to pay you 80% of any charges for the services or our policy holders or our insured people, and then you're gonna waive the balance. So you're gonna be placing a write-off. So that's another negotiation that they have. Because sometimes they tell, oh, if I have Medicare, I don't have to pay anything. If I have Medicaid, I don't have to pay anything. It's not that you don't have to pay anything. It's those charges actually are being waived by insurance or by the provider. Not that you don't have to pay for it, because if they don't waive it, then they're going to bill you. But because this is a government sponsor, insurance, so then, you have to kind of abide by these rules and regulations and not, just to do the write-off instead of billing the patient. Medicare Part A benefit period. So remember, it's not going to be done, oh, I'm going to be hospitalized for all this time. It doesn't matter, 6 months, 1 year. Medicare is going to pay for it. No. They have different regulations, remember. So the benefit period, or what is called spell of illness, which is, the acute condition, the moment when you actually got sick and you've been admitted. So begins with the first day of hospitalization and ends when the patient has been out of the hospital for 60 consecutive days. So that's basically what it is. So in other words, they just pay not for the whole period of time that the patient has been there. If you go and you spend more than certain time within the hospital, they're not going to pay for everything. Then they're going to send you to another institution that is going to be like, like having a secondary insurance. So I cannot keep you this much time. You need to be here. But then we cannot go after the days because the insurance is not going to pay. So we're going to move you to another institution and you're going to start there with another institution, is starting a new billing process. So that's how they play around with this. Lifetime reserve days, 60 days for your lifetime that's a reserve. Maybe you use only once during a patient's lifetime. So you have 60 days that you can use at any time during the time of your life. And after 65, how much do you think is left? So that's basically what it is. So after 65, you have 60 days that you can use at any time. This is like your sick days when you're working. And during the whole year, you have sick days, but you don't want to take it now. Said, no, I'm going to take it at the end of the year. Or I'm going to take them when I really need it. I don't want to take my sick days now. Because people think that sick days, I need to be sick. No. Sick days are, just some days that you are allowed to take and being paid for it. But you cannot take them all together. But if something happens, you get sick, you use your sick days. So you'll stay at home and you still get paid for it. The same goes with the 60 days after you reach the age of 65, that you can use it as a reserve for any situation, any unforeseen situations. So then you will be covered completely. But if you have a terminal illness, if you have something else, that is a different issue. Remember, this is just for medical services. So it's a little tricky, all this. So don't get much into this. Just learn that Medicare Part A pays for hospitalization. Forget about all these extra days or these benefit periods or lifetime reserve periods, because then you're going to get confused. Nothing. It's just part of the chapter, and, we need to cover it. So it's basically what we're going to do. Skilled nursing facilities. Now, for this case, remember, the other ones were hospitalizations. Now, this skilled nursing facilities is a nursing home. Must have a minimum of 3 days acute hospital stay prior to admission. Now, think about what I told you already. If you meet the requirements to be hospitalized, you cannot be more than 3 months, 6 months, 60 days, according to your plan, according to the policies on your stay. Then you're not getting better in the hospital. You still need to be in a place where someone is going to be taking care of you. But then we're not going to get paid here in this hospital. Well, we refer you, we transfer you to skilled nursing facility. So that's how it works. Because the hospital is not going to be covered anymore. The hospital is not going to be reimbursed after a certain period of time. So that's what it says right there. You must have a minimum 3 days acute hospital stay. You have to be hospitalized first. And because the hospital requires you to be treated not at home, but mostly in a skilled nursing facility, they're going to send you there. If you have 60 days and you benefit period has elapsed because after that the insurance is not going to pay, we move you to a skilled nursing facility as well. So this is like the second option that you have. Instead of sending you home or sending you somewhere else without services, we're still going to send you to a place when you can receive medical care. That's basically what it is. So again, must meet Medicare qualified diagnosis and comprehensive treatment plan requirements. Of course, if you don't have something that is serious going on with you and you can go home and just can continue taking your medications, well, it's not required to go to skilled nursing home. Because remember, skilled nursing home is when we have nurses, we have doctors that are going to be rendering services for you that you need. You need medications constantly to be given, treatments or wound care, dressing changes, and any other services that otherwise cannot be provided at home. So then we need to keep you in one of these inpatient facilities. Medicare Part A pays for it. Home health services. Remember, we talk about which services Medicare Part A are going to be covering. So hospitalizations, skilled nursing homes, now home health services. Not every home health services. Remember, some home health services will be covered by Plan B. So, or Part B, you will. Individuals receiving physicians prescribed Medicare covered home health services have no deductible co-insurance responsibilities for services provided. Now, once again, the patient is not going to pay much, remember, because the patient, the insurance company is going to pay 80%. Think about that. That might be a question for your exam. Medicare is responsible for 80% of all the costs of the services for this person, 80% of the bill. So what is the 20%? That will be the patient's responsibility, right? So that's basically what it is. So the patient is going to be responsible for the rest, the balance. But if the patient doesn't have no money, the patient doesn't have Medicare Part C or Medicare Advantage, well, who's going to pay and from where the patient is going to pay? Well, sometimes remember the medical providers have to waive this money, has to write it off because the patient is not going to be able to cope. The patient is too old. Remember, after 65, come on, who's going to be paying for all that? So that's how the system works. But if the patient has other means to pay, the patient is going to be charged. It's just that they're going to find out that the patient cannot pay. So they just write it off because they're not going to send the patient to collections. That's going to be a little difficult. And when the patient feels a little better, that can be treated at home, they can be sent home. Well, they are home already, right? But they were in a nursing skill facility or in a hospital. So it has these channels. From the hospital, you can go to a nursing care health facility or to a nursing home or to their homes. Depends on what conditions and what needs the patient has, medical needs. Because remember, at home, you can't render all these skill services. You might have a nurse that goes once in a while, but that's not the same. In a nursing skill home, you're going to have these nurses every day over there taking care of you because your condition needs, this type of services. So that's basically what it is. Hospice care. Remember, we talk about hospice. This is where terminally ill patients are going to be ending up, if that is the wish of the family of the patient. Remember, I say that because some of the family members, if they have the means to keep them at home, well, they have to have someone over there. And, you know, the insurance pay for a visiting nurse and a home attendant that is going to be taking care of the patient while the patient is at home. But if the patient has some conditions that are serious, cannot be taken care at home, or they don't have someone who's going to be taking care of home available, then they're going to be sent to a hospice. Remember, this is called like a cycle. From the hospital, we're going to decide where is this patient according to what conditions the patient have. We're going to send them to skilled nursing home, to to a hospice if it has a terminal illness, or they're going to go home. Remember, terminal ill patients, they don't need much treatment. They just need some comfort, some relief of pain, some palliative, because that's what it's called. When we just relieve them from pain and we give some type of, dignity of, what they are there. We don't expose them. We treat them with care. They have a priest that comes over, whichever religion you have. You can practice your own religion there to give you comfort, some, psychologists that they come talk to you, preparing you because you are a terminally ill patient. You're not going to get better. So this is the last stuff for you. So that's basically what it is. You're going to get some psychological, sociological, or spiritual help and assistance. So for your exam, mostly, they're going to ask you, what is the services that the hospice provides? So you know already that this is for terminally ill patients, but the services that they're going to receive is relieve them from pain and other discomfort. And what term we use for that? Palliative care. Palliative care means relief of pain and other discomforts from the patient. They are emotionally disturbed because they know they're gonna die soon. We're not gonna do any testings or any procedures. No, nothing is gonna be done to that. They're gonna be giving pain medication. They're gonna be giving food. They're gonna be giving, consultations with the priest, with the psychologist, sociologist, all those things. So that's basically what happens over there at the hospice. So remember, palliative care is what patients who are in a hospice care are going to receive. There is no doctor that's going to go there to diagnose you. If you develop something during the time that you're there, we're just going to give you pain medication. They're going to clean you, they're going to feed you, and that is it. No treatments for anything. So you have already diabetes. Are we going to give you medication for diabetes? No. You have hypertension. I'm going to give you medication for hypertension? No. They're just going to give you medications to relieve pain, just to keep you, calm, comfort. They're going to have your family visiting you. They're going to have other groups of people visiting you to make you feel like you're not alone, just kind of thing. So supporting, care that they do. So that's what you have to understand. So palliative, remember, don't forget palliative because it's going to be there. They're going to talk about hospice, and the services that they receive over there are palliative services, palliative care. That's it. And what is it? Relief of pain and discomfort. They're going to make you, pass the last days of months of your life with, to die with dignity, without suffering. So that's basically what it is. Any questions? This is not the same as a nursing home. No, it's not. Yeah, patients die in the nursing home, but that's not a hospice because these patients do not have a terminal illness. Terminal illness is someone who already have a diagnosis that is telling you, you don't have much time to live. So that's basically what this is. Participating providers. Now, we talk about participating providers. So anyone who signs up with any of the insurance, in this case, Medicare, they have an agreement. Okay, so I want to take your patients. Every single medical provider, whether it's a single medical doctor's office or a hospital, they take Medicare because they pay well. So Medicare pays better than Medicaid. So Medicare, remember, any single medical provider takes Medicare. They sign for Medicare because we have lots of patients that have Medicare. Remember, they pay 80% of all of the services. And that is guaranteed you have the money there. So that's basically, well, of course, if you file the claims correctly, right? So that's basically what it is. So these participating providers have accepted assignment. Remember, accepted assignment is I receive the money that you're offering for all these services. If you're gonna pay me 80% for the total amount of services, I'm agree with, no problem. If I'm agreed that I'm not gonna be billing my patient for the balance, that's what you're gonna do. And most of them, they ask you to agree with that. Just receive the 80% and the 20%, you do not bill the patient. So those are the agreement. Remember, that's a accepting assignment. That's the provider. What happened to the non-participating providers? Remember, non-participating, you did not contract with the Medicare or with any insurance for that matter. So now, in this case, Medicare is still going to pay you, but that's going to be in a claim by claim assignments. But once again, now you have some restrictions. Remember, now you definitely will be prohibited to bill the patient for the balance. When you are participating provider, you can bill the patient. You have a contract, but you can bill the patient still. But if they don't pay you, you have to do a write-off. But in this non-participating provider, you're only going to receive the 80% and that is it. Because now you have a clause there that the balance cannot be, charged to the patient. So those are the difference. And then you can receive or not receive Medicare under these conditions. Remember, non-participating provider means you did not sign up with this insurance. You did not. So if once in a while you want to take it, that is different. But to be honest with you, I believe that 99% of the providers has Medicare. That is for sure. We receive Medicare. It's very good insurance. They pay well. So the non-participating providers, just put it over there because it's got to be an exception to the rule. It might be one or two that don't want to be participating with Medicare, not a problem. They just want to take private insurances. So that's fine. They can do it because you are free to select whose insurance you're going to contract with, whether you want to participate or not. But for Medicare, believe me, almost everybody. This is another term that you need to remember for exams, because a lot of terms right here for insurance, that's what we cover insurance. Advanced beneficiary notice. Now, thinking about advance means something that is being communicated to you in advance. It's like the advance directives. I'm gonna be telling you ahead of time before I get sick that somebody can make decisions on my behalf. This is an advance directive because in advance I took measurements. I took the step to sign one of these documents to allow someone else to make decisions for me if I'm not allowed to do that myself. Here we have an advance beneficiary notice. So this is an notice that is given to the patient in advance about what benefits are going to be covered by your insurance. So that's basically what it is. So if this insurance, we're going to tell you, this insurance is not going to pay with this service. Now, it's not that this is going to be done only at the beginning of, when you register, because you're going to forget about this. It's every time that the patient has to go through the procedure and the procedure is not covered or it's not covered in its full or in full for the services, now you're going to receive this notice. So this is what actually states. It is a written document provided to Medicare beneficiary by a supplier, physician, or provider prior to services being rendered. Now let's explain all these type of services that you might receive. So I'm the beneficiary of Medicare. What is a supplier? Well, a supplier is someone who provides supplies to me because I need it because I have a condition. It might be a wheelchair, it might be crutches, it might be a cane, it might be a walker, it might be an oxygen tank, it might be any other supplies that I need due to my condition. So I have to be, notified in advance that I might not receive all the things or might not get paid or the insurance might not cover for all these supplies. Now, physician as a provider, now that changed because that's for medical services. So remember, I was just trying to clarify the supplier because you said, what do you mean? The insurance paid for the medical services. Yeah, what about the durable medical equipment? Who's going to pay for it? The physician don't pay. The insurance don't pay if it's not covered. So then who's the responsibility? The patient or the patient's family, right? So here it is what an advanced beneficiary notice means, which is called ABN. That's what it's called. We use acronyms. And this will be asked on your exam. So it says right here, an advanced beneficiary notice indicates that the services are unlikely to be reimbursed by Medicare. So any services that are unlikely to be paid, covered by your insurance, you need to know in advance. So that's basically what it is. So then there is no surprises. Remember that one of the major drawbacks of communication with the patient is not clarifying to them today how payments are going to be done. Because the patient assumes that the insurance always going to cover everything. But that is not the case. It goes in different ways. And depends on the circumstances, depends on the services needed for the patient or the supplies needed. What procedures are needed, whether they are coverings, it is entirely or it is just partially covered. Reimbursed. Who's responsible for the balance ends up on the patient. So the patient needs to know, because if something happens, the patient already knows that this service is not paid because it's not covered by their insurance, and that's their responsibility, not the doctor's responsibility. In other words, the patient cannot sue the medical doctor just because this procedure was not done or these supplies were not provided to them. We have to cover ourselves. all the time. That's why we have documents. That's what we have to do documentation in the medical records to keep all the information, track, and all the conditions of the patient, medication, diagnosis, procedures, and also the financial part to see what we have been reimbursed for, what has not, what has been denied, so we don't make the same mistakes again. But this is written in the Medicare and any insurance. Those part of the policies. This is covered, this is not covered. So if you have this problem, so we're not gonna go over everything with the patient. We're just gonna tell them, you know, your insurance might not pay everything. If the insurance does not cover it, you will be responsible for the balance. But anytime that you get into a situation that you have a procedure, we're gonna let you know. Every single time that we encounter these situations, we're gonna remind the patient, okay, there is a procedure that, you know, I recommend you to have because of the conditions that I diagnosed you with. But then the insurance do not pay the full amount. You are responsible for the balance. Are you agree or disagree? You have to sign this document. So that's basically what it is. So then if something happened to the patient because he didn't get the procedure, they're not going to sue the hospital. They're not going to sue the hospital. They're not going to sue you. They're not going to sue the insurance company because they were aware that, you know, it was up to them pay for the services or not because the insurance did not pay. Or you have to get another insurance that is going to pay. So that's how it works. So we always going to have documentation to protect ourselves. And we have to make them aware of all these documentation. So remember, advanced beneficiary notice will be asked in your exam. Explanation of benefits, EOB, it will be asked. RA, remittance advice, is gonna be asked. So you need to know these things, because if you don't, then you're gonna miss on very simple details. I will give you these questions. See, here it is. A beneficiary who signs an ABN agreement. See, you have to sign this document. This is like an advanced directives. This is like a release of information form. You have to sign it. So then we have on file that you actually were aware of these policies. Because if we don't have an advanced beneficiary notice on your files and something happened to you because the procedure was not done, the medical provider cannot come out with the issue, oh, well, the insurance didn't pay for it, so we didn't do it. No, what is the beneficiary notice? Signed by the patient, I need to see it. Did you inform your patient about, you know, having other options or, you know, then their insurance were not covering that, but yeah, you informed them, but what is the written note? Remember, if you did not record it, you didn't place the entry, if you didn't write it down, it means it didn't happen. I've been saying this so many times. I'm not gonna say for what, because some of you know. But that's how it is. Remember, if you do not record, do not document information, and then it's required or it's needed, it's not there. It wasn't documented, it wasn't written. That means it didn't happen. So there is nothing there. So we have to request the beneficiary to sign an agreement that guarantees personal payment for services. See? The insurance does not pay for these services, so you gotta be responsible for it. No, I'm not gonna pay for that, blah, blah, blah. No problem, sign this document because that's exactly what, you know, your insurance, the plan that you have, whether it's Medicaid, Medicare, whether it's Oxford, whether it's United Healthcare, Blue Cross, any insurance, that's for anyone. If it doesn't cover services, doesn't cover, because remember, if the insurance do not cover the services, we don't get the reimburse, period. That's why we give you this advanced beneficiary notice. So you know that these services can be provided, but we're not going to get reimbursed for it as providers. So for that reason, somebody has to pay. That's going to be you, the patient. When I said the patient can be the family, but it's not going to be the insurance. So that's basically what it is. So an advanced beneficiary. So I always read this, the title, advanced beneficiary notice. So I just go for it. And I started trying to, define each one of these terms, because that's what's going to give me the answer. Advance, okay, I have to give you this in advance. I have to give this prior for you to receive your benefits. I'm going to give you this notice prior for you to get your benefits. But the insurance is not going to pay for these services. So it's not going to pay a full payment or in full or partially payment. You're going to be responsible for the balance or for the entirety of the payment. See, that's how you look at it. Explanation of benefits is the same. I'm going to explain you what services were rendered to you, and that's to the patient. So that is how it works. Think about the wording, how to define each one of these terms. You're going to get the answer to the questions. Remember, it's understanding the question. It's not just, oh, I know the answer. Yeah, but the question is asking you something else about that answer. Yeah, that probably is the right answer if you were kind of asked straightforward. Sometimes they don't ask you like that. It's kind of implied. So the purpose of the ABN or the Advanced Beneficiary Notice, see, I use acronyms. Why? Because if you get an acronym, you're going to know what exactly they're talking about. But if I don't, you're going to be lost. What is ABN? I'll have no idea. You're just going to make that up. You're just going to try to figure it out. It's not good because you're guessing. It's to document that beneficiary has received notice that a service is unlikely to be reimbursed by Medicare. Now, this is not just to Medicare, it's to all the insurances. Every single insurance has an advanced beneficiary notice. Why? Because not every single service procedure it is covered by the insurance. And the patient needs to know it before getting the service. See, if we don't, then that was an uncovered service. We get a denial on our claims, insurance claim. So I repeat this all the time because it's important for you to go over and over. If I just mention this once, what's gonna happen? You're gonna completely forget. I go over and say it once, but if I keep on repeating this and bringing it back in different chapters, in different slides, in different modules, you're gonna say, oh my God, I've been hearing this so many times. It's like, a revolving door. But that's how you are going to be recalling this information. And that's a good thing. That's what the textbooks use, this technique. But some people don't understand that. Said, oh, you mentioned that before. It's like, repeating all over and over. But that's the process, because that's what we do. When we're going to learn something and we're going to get good at it, you have to repeat it over and over and over until, without effort, without thinking, we're going to know how to do it. And that's how we get confident. That's how we know how to do things. Medicare as a primary payer. I already mentioned this, but once again, we're going to go over. Remember, let's put it this way. Forget about much of the stuff that is there. We're going to go over that, but still, because that's not the way that actually in real life works. Because not all your patients are going to have, end-stage renal disease. Not all your patients are going to have that. So once again, yeah, Medicare is for someone who is 65 and older, but not necessarily for all other exceptions. So the questions when you get an ear exam, what you have to understand in general is Medicare is a primary payer when you do not have a private insurance. If you have a private insurance that you purchase on your own and you have Medicare, Medicare is secondary. Your primary pays for it. You're working, you're still working, you're 65, but you're still working. You have insurance from your job, your group insurance, but you also have Medicare. Medicare is secondary payer because your group insurance is your private insurance is gonna be the primary one. So if you learn this the way that I'm telling you, you're not gonna have no problems answering questions regarding to Medicare as a primary or a secondary insurance. Now, you don't have any group, any private insurance. You don't have. You have Medicare, which is the primary, Medicare. You have Medicare and Medicaid, which is the primary, Medicare. Because Medicaid is the last resort. Hear me this, because we're gonna have Medicaid next. The next chapter is gonna be Medicaid. So you're gonna understand that Medicaid is gonna be the primary when you only have Medicaid. But if you have Medicare, the one that we're talking about now, and Medicaid, Medicare is the primary. So Medicare pays 80%. Remember, hear me that Medicare pays 80% of any services, always 80%. So if you have Medicare and Medicaid, Medicare is primary, Medicare is primary, Medicaid is secondary. So Medicaid pays the 20% that is left because Medicare only pays 80%. So that's what I want you to understand because that's the best way that you can learn who's the primary. Medicare, when you have a private insurance or your group insurance is considered private. Regardless of what group insurance you have. Remember, group insurance is the insurance that you have through your employer. So that's basically what it is. So let's read what it says right here. So, but I got the information that you need. I delivered the information that you actually need because it's a lot easier. Now, you know that if you are under 60, the patient is under 65, has Medicare because of disability. And what is those major disability that you qualify for? ESRD, which is end-stage renal disease, remember. Don't forget this, because this is very important. And it's not covered by any employer-sponsored plan. See, that's what I told you. If you have Medicare and you do not have an insurance from your job or an insurance that you purchase on your own or your wife, then Medicare is going to be the primary. So in other words, Medicare is the primary if you don't have another insurance, period. If you have Medicare in another insurance that is not Medicaid, Medicare is not going to be the primary. It's going to be the secondary. If you have Medicare, Medicaid, Medicare is primary, Medicaid is secondary. Medicaid is never going to be the primary if you have more than one insurance, never. So Medicaid will be primary only if you have Medicaid. But Medicare, on the other hand, it can be secondary or it can be primary. See the difference? Medicaid never can be a secondary because or it's primary. That's it. This is the last resort. The patient is under 65, has end-stage renal disease, and has an employer-sponsored plan, but has not been eligible for Medicare for more than 30 months. Now, this is not a question that is going to come on your exam. Because in this case, you have not been on Medicare for more than being eligible for Medicare for more than 30 days, for 30 months. So then it will be primary. But these cases are very rare, remember, because now you have to have ESDR. So who has all those things and he has unemployment is very rarely. Because after you develop this condition, then immediately, you automatically can qualify for, Medicare, regardless if you are under 65. So just know what I told you already, when Medicare can be primary. That's it. If it is standing by itself, Medicare is primary. You have Medicare, Medicaid, Medicare is primary. That's it. That is the only time that Medicare is primary. So if you have any other type of insurance that is not Medicaid, then your employer, your own insurance is going to be primary. Medicare will be secondary. I hope you got that information because it's very important. Death of employee spouse. Remember that you are, you kind of sponsor the other person, because you can have Medicare if you as the primary beneficiary, as the primary policy holder, because you are the one who works or work for this company. You have not retired yet. It's time for retirement, but you still continue working, but you are older than 65 and you have a Medicare. Now your spouse is entitled to Medicare. But the spouse dies, whether the one who has Medicare or the one who doesn't have it, still, if the one who has Medicare, the one who has the primary policyholder dies, so the person who actually worked and got this policy, but the wife or the husband dies, they still depends. They're still going to be receiving that Medicare, and it's going to be the primary for them. Loss of employment or reduction in work hours. Now, if you lose your employment, what happened to your insurance? You lose your insurance as well. So then, if you have Medicare, remember, you have to be over 65. If you have end-stage renal disease, you're not going to be able to work. So don't think about that. That is an exception to receive Medicare if you are not 65 yet. That's a different issue. Of course, you qualify for Medicaid, so you're going to have both. You divorce. It's like you divorce someone, it's like the person dies too, because the person is no longer with you. So then Medicare is going to be your primary. So it's going to follow you because you have the insurance or your spouse have the insurance regardless. So you're going to be, you're going to be covered anyways. Because you were covered before the divorce. You were covered before your spouse passed away. So you continue with the insurance. That's how it works. Medicare as a secondary. So we talk about Medicare as a primary, now as a secondary. An employer-sponsored group, I already told you this. So once again, if you have still working after 65 and you have Medicare and you have your employer are going to be the primary one. So Medicare is going to be secondary. That is it. Do not worry about the number of employees for this company, blah, blah. There is no such a thing here. So again, just the fact that you have an employer's insurance, that's it. That's going to be your primary. Medicare moves to secondary. Do not worry about anything else because you are not dealing with the billing, the classification for the billing and coding. So that's something that you're not going to be asked at all. And it's something that you actually don't need it. An end-stage renal disease case covered by an employer-sponsored group plan or any size during, once again, Medicare is going to be secondary because you already have a employers or employer-sponsored group plan. Period. The employer is always going to be the primary. Your primary insurance, your own insurance is going to be the primary one. We're not talking about Medicaid or Medicare. Something that you're paying from your pocket. It's a private insurance, a commercial insurance. Always going to be primary. Medicare will be secondary. You don't have those, then Medicare is the primary. So that's A. Medicare Secondary Payer Program coordinates benefits between Medicare and additional payers to determine if an additional insurance plan is a primary. So really what happens right here is that the insurance job, the billing department job is to determine which insurance, the ones that you have, is the primary. And when you send these to the insurance company, when you adjudicate this insurance claim to the company, the insurance company that has the employer or the patient as the client, the policy holder, they're gonna make sure that they are using this correct determination, that they know which one is the secondary, which one is the primary. Because we always have to think about what is the primary and secondary when you have more than one insurance. That's the only time. Remember, if you only have one, that's your primary. I only have Blue Cross and Blue Shield. Well, that's the primary. I have Medicare alone. That's the primary. I have Medicaid. That's the primary. I have Blue Cross Blue Shield, but I also have Medicare. Who's the primary? Blue Cross Blue Shield. Who's the secondary? Medicare. I have Medicare and Medicaid. Which is the primary? Medicare. Medicaid will be the secondary in this case because Medicaid never going to be the primary if it's not the only one. So that's basically what it is. So we need to keep in mind all these so we can understand exactly how to select, because they're going to ask you about, okay, the patient has the employer group sponsor plan and it has Medicare. Medicare in this situation is which type of payer? Secondary. Secondary. You have this person has Medicare and it has Medicaid. Who is the primary payer? Medicare. Period. That's it. What is Medicaid? We'll discuss when we get into the next chapter. But Medicaid is always the last resort. Always. That means that it doesn't count until we don't encounter anything else. Because first we go for the private or the employer, which is the private one, or commercial insurance, and then the government. So the government never going to be the first one. We're going to charge the private first and then the government. And if you have two government, Medicare and Medicaid, well, Medicare will be the primary. Any questions? So we're going to have these contractors. Some of them going to identify insurance primary to Medicare. So these are mostly these contractors from Medicare. The ones that are going to be helping you with enrolling, and they're going to be contacting the IRS for, the amount of dates or months or years that you work and how much you get paid, how much money was deducted, and so on and so forth. We should not be worried about these at all. So we just need to understand when Medicare is considered primary or secondary. And when we get to Medicaid, we're going to talk exactly the same way that we talk about Medicaid, and then we're going to talk about Medicare, who qualifies, and all the details about the insurance, because that's how it's going to play out. So that's a lot better. Any questions about Medicare? Because we're done for today. Tomorrow we're going to be covering Medicaid, and after that, workers' compensation. And if we have a little time, then we add a little something else just for you to know. But let's see how it goes. Okay. Any questions? Any questions at all? Okay, so then we're done for tonight. Have a good night. Thank you for attending the class. Tomorrow's another day. Once again, if you have not submitted your final exam from medical, what was that? Medical record management, then please do so. And for those one who submitted, well, you have the results already. So let's see how it goes. All right, so good night. Thank you again. Take care, stay warm and safe.
Good night.
Good night. Take care, Lily. Good night.